Hi, my name is Mark Nagel, and along with my co-authors Dr. Jason Suggett and Dr. Jolien Mitchell, we'd like to share our work with you where we question whether the pressure drop of more than 10 centimeters of water with any DPI is a reasonable threshold above which a patient should receive an adequate lung dose. Basically, also talking about part of our method validation and experience with a sample cohort of COPD patients. As we know, DPIs have a wide range of inhalation flow resistance, as seen by the graph from Clark et al. It's important to understand how the patient inhalation profile might influence the efficiency of medication delivery. Clark et al. Have shared that based upon their study, pressure drops in excess of 10 centimeters of water with any DPI is at a threshold above which an adequate lung dose can be achieved. So our study was undertaken in two parts with the following purposes. One, we wanted to validate the model against a standardized inhalation flow profile generated by an in-house breathing simulator, and two, to use that system to assess DPI-delivered medication delivery from inhalation profiles captured from a small cohort of COPD patients. The goal was to determine if the inhalation profile, in particular the maximal inspiratory pressure, or MIP, influenced medication delivery efficiency by collecting the aerosol in the filter, representing the portion of the inhaled dose that was capable of reaching past the carina and therefore potentially available to delivery to the lungs. For this study, we obtained the inspiratory flow profiles from 5 patients of varying levels of COPD. Each patient inhaled from a placebo turbihaler as a purpose-constructed attachment to a pneumatac, as shown in the photo here. Each inhalation profile was recreated with 3 replicates each via an Ingmar ASL 5000, and for this study, the label claim of the turbihaler DPI which we used contained active ingredients of 80 micrograms budesonide and 4.5 micrograms formoterol furoate. The DPI was chosen because the COPD patients already were prescribed this as part of their normal treatment regimen, and therefore they had already been trained and coached and have developed an understanding of how to use the device. Once the recordings were obtained, they were brought back into the lab and simulated using the ASL 5000. We constructed the apparatus as shown here in the image, whereby the turbihaler is connected to a model oropharyngeal airway, the filter interposed between the airway and the ASL, and then the inhalation profile recreated. We wanted to ensure that the pneumatac measurements we were recording were valid. We were using a SpiroQuant disposable flow sensor along with a Hans Rudolph breath recorder. The disposable flow sensor is less accurate than a reusable, but for the sake of hygiene, we chose to use a disposable unit. So what we did was we had a 500 cc tidal volume that was recorded using our setup, generated by our ASL, and looking to determine how close we were to the recorded values. And as you can see here in the table, we're very close in terms of tidal volume as well as IE ratio. So tidal volumes reported by the flow sensor recorder are almost identical to the standard value. However, the value provided by the breath simulator is about 1.2% higher. IE ratios determined by either method were slightly greater than the nominal values of 0.5, and breathing rates were correspondingly longer. However, the divergence between the measured values of the two techniques was only 5.6% and 1.1% for the IE ratios and breathing rate respectively. This may be a result of the sampling frequency between the breath recorder and the ASL. However, the flow sensor recorder was therefore deemed suitable in obtaining these patient-generated inhalation profiles. The COPD patient-generated flow rate profiles together with the corresponding maximal inspiratory pressure values are shown below. Variation in the start time of the various inhalation profiles is shown explicitly to show the differing amount of delay from patient to patient. The inhalation flow rate time profiles vary greatly from one patient to another in both terms of amplitude and duration, with an associated variability in mean inspiratory pressure values ranging from a minimum of 11.5 to a maximum of 50 centimeters of water. Peak inspiratory flow rates exceeded 30 liters a minute for all patients, a threshold reported by Broders as being sufficient for the turbihaler DPI to provide a therapeutic dose, although these authors observed that a flow rate greater than 60 liters a minute would be required for optimum medication delivery to the lungs. Massive budesonide and formoterol components of Symbicort collected on the filter distal to the model are presented below. The upper airway deposition within the model was recorded with similar variability to the mass of the APIs recovered from the filter. The replicate measures per patient-generated inhalation profile for each component, that being budesonide and formoterol, were generally consistent, with coefficients of variation under 10%. However, there was an exception from patient C where the coefficient of variation was close to 25% without a cause that we couldn't assign. More importantly, the mass of either component varied widely from one inhalation profile to another. Our largest values were 35 micrograms of budesonide and 1.8 of formoterol associated with patient E, who generated the highest mean inspiratory pressure of 50 centimeters of water and inhaled for the shortest duration of only 1.8 seconds. Conversely, the next to smallest masses of each component, 16.2 micrograms budesonide and 0.8 of formoterol, were recovered when the inhalation profile from patient B was at its lowest mean inspiratory pressure of 11.5 centimeters of water, inhaling for the longest duration of 6.8 seconds. The large variability in inhalation profiles that we observed was expected, as it's been previously shown that from at least one carefully designed study that such variability exists with COPD patients when they were instructed to inhale through their usual device without training to achieve a target maneuver. The present findings indicate that settling on a MIP threshold of just 10 centimeters of water to receive an adequate lung dose may be an insufficient criteria. There is therefore likely to be potential value in having further discussions about these questions. What is an adequate dose, and what other factors in addition to MIP may be important in achieving that target? There's some obvious limitations to our present investigation in that it's a small patient cohort. These patients were chosen at random at the beginning of what we'd hoped to be a larger study, but was limited due to COVID-19. They were chosen basically because they could use the turbihaler. It was part of their normal treatment regimen, and no coaching was involved to improve their inhalation technique. Another limitation is that only a single profile was obtained per patient, rather than looking at the best of several attempts. One of the concerns in doing this, however, is that these patients are all elderly, all compromised with COPD, and that in itself may provide an interesting investigation. This in vivo in vitro investigation with a medium resistance DPI indicated large differences in breathing profiles and consequently large differences in observed drug delivery. It's highlighted the fact that there's a potential mismatch between a proposed lower limit of 10 centimeters of water for MIP and likely medication delivery efficacy to the lungs of patients with COPD. Notwithstanding the limitations of a small cohort of patient profiles, we believe there is merit in further discussions around what is an adequate lung dose and what other factors in addition to pressure drop might be involved. Thanks for your time.